Welcome to the topic where we're looking at psychological aspects of pain management. Now, this is a German psychologist by the name of Hermann Rorschach, and he was famous for the Rorschach ink blot tests. And this was used to assess patients' cognitive function, cognition, as well as psychology, and I think personality aspects as well. So through the talk you'll have some of his ink blots in the bottom corner of the slides, and you can see what you come up with. Your thoughts, that is. So this is how we're going to structure the topics. We're going to look at the psychologist's role and how they fit in with multidisciplinary pain management. When to refer patients to psychologists and when you think that psychologists should be involved, what their treatment approaches are, and how best to go about measuring pain, or not how best, but various aspects or options that are available. This is important as a pain specialist, and of course important for exams as well. So the psychologist's role, a psychologist can do a number of things as part of your pain team or part of the pain team, but one of the main things is assessment, and it's assessing various aspects of some patients. So patients that have abnormal behaviors and cognition, so the maladaptive behaviors and cognitions, and I say these two phrases over and over again because it is so important with pain management. Patients that have abnormal emotional states, so those with depression and anxiety, those that have had stressful events that have precipitated their pain or possibly made it worse, so stressful life events, cancer, trauma, death, bereavement, problems with work, and also pre-existing factors, so things like not depression, abuse, neglect, those kinds of things can also play a role. So if you're hearing about this or sensing this from your patients, it might be worth talking to a psychologist. So this is what I've mentioned again, and I do mention this over and over again because it is so important. It's changing negative behaviors to positive behaviors, as well as negative cognitions to positive cognitions. So the negative behaviors that patients have, and you'll see them time and time again if you look for them, they are inactive, they rest a lot, they display fear avoidance behavior. They display boom-busting kind of activities. They're unmotivated. They take medication to cope with the pain, and these are called chemical copers. And this is completely incorrect use of medication. So negative behaviors. And then the negative cognitions include the catastrophizing, the praying, the hoping, having a high external locus of control. So in other words, the situation I'm in is completely out of my control. This is all because of bad luck and fate. So external locus of control. And the aim again is to move them over from the negative cognitions to positive cognitions, negative behaviors to positive behaviors. So pacing, better lifestyle, using medications appropriately, the cognitions, the relaxation, the diverting, the reinterpreting, and really changing the way they focus on their pain, or taking their focus away from the pain. And this kind of approach to management happens every time you see a patient. You're reinforcing good behaviors, you're not talking about bad behaviors, or you're educating them that bad behaviors are just that, and you're giving reasons why. So this is the psychologist's role, but it's everyone's role that has contact with patients, so a lot of overlap. And then the psychologist can be involved in other aspects, so treatment, of course, research and teaching, and I'm sure there are other things that the psychologist would be involved in, possibly setting up services and setting up psychological testing. But those are the main aspects of the psychology's role within a multidisciplinary team. So when to refer, so you can have this in your mind, and I've used it as a way of crystallizing your thoughts when to talk to psychologists and get patients to see psychologists. So when patients come in with odd histories, inconsistent, vague histories, when you've picked up your flags, so your yellow psychosocial flags and other flags as well, when they've significant lifestyle changes, then they're displaying abnormal behaviors, abnormal cognitions. When surgery and treatments have failed, Now I've got an asterisk on that because in an ideal world, people shouldn't have failed treatments. They should be assessed beforehand, but most of the time they don't get to be assessed beforehand. And it's not uncommon to see patients having significant surgery, say for spinal problems, and come back immediately after the surgery with the same problems, and they haven't been assessed appropriately beforehand. If they're taking too many medications or therapy, so they're really using their resources around them, that's another reason to get them to the psychologist. Try and get an idea of what's going on, why they keep on coming back. And of course the other one is if the patients are inactive. This is important to discuss with a physiotherapist as well, but of course psychologist is important here as well. So high levels of inactivity, talk to the rest of the team. And then if patients come in knocking on your door saying, I want to manage my own pain, I want a pain management program, we'll get them to the rest of the team quickly because they're open and they're willing to change. Now the treatment approaches, you've seen this before, and I'm giving this to you again because it is so important, and this is your treatment approach for all patients. And now because we're dealing with psychology and we're talking about psychology per se, you can see we can focus on the psychological aspects, and it's all there, and it's the same approach. You can adapt this for each patient. Get them involved as an individual, as a group. Get them participating in their own treatment, so taking charge of their treatment, being active. And then it's about stress reduction, cognitive restructuring, behavioral modification. I've said it before, I'm saying it again. That's the basis of cognitive behavioral therapy. Dealing with anxiety, mood, sleep, confidence, and everything else that's surrounding the patient. Getting them confident, excuse me, getting them self-efficacious, so increasing their self-efficacy, reducing the catastrophizing, and getting them out there, getting them looking after and managing themselves. So the psychological approach. And every approach, again, repetition comes down to education somewhere along the line. So educating the patients on what's going on, and the cycle of education. The cycle of education is assessing where the patients are, teaching them something new, letting them go out there and practice these new skills that I've acquired, and then coming back and rehearsing and repeating those skills, and then you're reinforcing in the positive aspects, and you're getting rid of the negative aspects. So the measurement of pain, there's a lot that we're going to be discussing here, but it is important, and I want to get it across to you. So the commonest multidimensional assessment for pain is the McGill Pain Questionnaire. And there is not McGill, but that's Ronald Melzack, who devised the McGill Pain Questionnaire at McGill University. And there are three aspects to the questionnaire. There's the diagram, there's a present pain intensity, and that's just a 6-word verbal descriptive rating scale, so no pain to excruciating pain. That's the present pain intensity. And then the quality of pain, which takes 78 words, divides them into 20 sets, and each set categorizes sensory issues, affective issues, evaluative, and miscellaneous. And I'll explain that further in a second. So there's the McGill questionnaire. There are your three aspects. The PPI, which is a little red at the bottom. There's your 6-scale verbal descriptive scale. That's 6-point. There's your diagram for the patients to draw on and show them where the pain is, or where the paresthesia, whatever it might be. And then you've got your quality, your 78 words divided into 20 sections. So the PPI is marked up on the top of the questionnaire. And then the pain rating index is made up of the 20 subsections of the quality word descriptors. So the pain rating index is an additional feature. So there it is, made up of the 20. So the sensory aspect, which is the first 10 sections. The affective aspect, which is the next 5 sections. Section 16, which is the evaluative aspect. And then the miscellaneous is 17 to 20. And you add those all up and you get your pain rating index. Okay. Measuring pain. Moving on, the brief pain inventory, commonly used. I've used it in all the pain clinics that I've worked at. It is very useful. Find out what your local pain clinic is using and have a look through them various measurement tools that they use. So what it does is it assesses the pain in the last 24 hours. So when the patient actually fills it in, and it assesses the pain and how severe it is, and how it impacts various aspects of the patient's life. So the aspects of the patient's life include general activities, mood, walking, are they able to work, how it interferes with their relationships, sleep, and ultimately enjoyment of life. So that's the pain and its impact. And then there's also a section to fill out the medication that the patient's taking, as well as the amount of relief that they're getting, and that's normally in a percentage from 0 to 100%. How much relief have you got in the last 24 hours from your medication? And there is also a body map for the patients to mark on where their pain is. So the BPI is quick, simple, easy, it's validated. The higher the score, the higher their interference. And the good thing about it is you can do it before you start treatment and after you start treatment, and see how the pain has changed and how the patients are responding to treatment. Now the SF36, the short form 36, is a health survey, and it's a general survey, and it measures physical, emotion, mental and social health, and how each various construct of these interferes with the patient's daily activities. 11 items, some with sub questions. The higher the score, the higher the function. And there is the SF36, just broken down into physical health and mental health. And there are 8 subsections, as you can see. I'm not going to spend too much time going on that. Just one point, the role, there's 2 kinds of roles. There's the physical role and the emotional role. So they roll physically and they roll emotionally. And interestingly, there's also one on vitality. So how they enjoying life and how much energy and vitality do they have. Right, measuring pain, we're moving on. The Beck Depression Inventory, so the BDI, a measure of depression, and there are a lot of measurements out there. This is one that I'm familiar with, and it's quite widely used. 21 questions, each looking for answers from 0 to 3, so a 4-point Likert scale. And these are the topics, or the 21 sections that are questioned on. So sadness, loss of pleasure, guilty feelings, crying, agitation, loss of interest, and it goes on. So for example, you've got the sadness one there from 0 to 3. I do not feel sad, I feel sad, and then all the way to I'm so sad or unhappy that I can't stand it. So 21 sections. And there is your ratings or scorings. From higher than 29 out of 63, the score, you've got severe depression. So the higher the number, the higher the depression. State trait anxiety inventory, so this STAI, 20 items, I feel. So there are your 20 items, and the patients are asked to describe how they feel with relation to that item. So I feel calm, that's the first item. Not at all, somewhat, moderately so, or very much so. And as you can see, the higher the score, the higher their anxiety. Coping strategies questionnaire, important, and I didn't really get my head around this until I started seeing quite a lot of patients and really delving into the ways that they cope with pain. So this is very important. And part of the coping strategies questionnaire is the catastrophizing, whether patients are catastrophizing. So there's 27 items. Never do that, to always do that. And ultimately it's looking at 3 sections. Coping strategies, so positive coping strategies, which you've got there and we've discussed, and it's important. And then the negative coping strategies, catastrophizing, prey hoping, and increasing pain behaviors. And the third one, because I said there were 3 sections, are the effectiveness ratings. So how do they feel they're in control of their pain? So coping strategies. Moving on, the self-efficacy questionnaire. And this is essentially a measure or a test of whether the patients have confidence to do something while they're in pain. So 0, not confident at all. 6, I'm completely confident I can manage that. And it assesses how they're able to enjoy things, what are their household chores, confident to not, or not confident to completely confident, socializing, working, and having a normal lifestyle. So self-efficacy, and you don't have to do this formal test. You can ask patients when you're seeing them, how confident are you in doing X, Y, and Z, 1, 2, and 3, and get an idea of what their self-efficacy is. And that's important, because if it's not good, you may want to discuss things with a psychologist to have ideas about improving them. So high scores, high self-efficacy, good. The Oswestry Disability Questionnaire is also very commonly used, particularly for spinal pain, and I'm not going to go into it. There's 10 sections, and the 11th one is on previous treatment. And then there's a various score for the 10 sections, and you do just a bit of calculation and a bit of fancy work, and you come up with a percentage disability. I think a lot of the insurance companies and medical legal work is done using the Oswestry Disability Index. And there's one for back pain, so lower back disability, and there's one for neck disability as well. The survey of pain's attitudes, and that's the patient's beliefs and how they are adjusting to pain. Looking at whether they feel all the way from true, very untrue for me, all the way to very true for me. So how are they adjusting with regards to the control, disability, and a couple of other things. I'm not familiar with this. I know that in one of the pain clinics I work in, it is used. So patients' beliefs. The pain stages of change questionnaire is very interesting. It's their patient's attitude to self-management. So, you see some patients and you've got an idea that they're pretty good and they're ready for a pain management program. Or you see a patient go and say to yourself and your team, this patient is way off from accepting self-management. And this is just formalizing those thoughts that we have every day anyway. So what are the stages of change? Are they in the pre-contemplation stage? Are they contemplating changes? Are they getting ready for change? Are they changing? And are they actively doing it? So there's stages of change. And of course people can be in various parts of this and relapse as well. The Global Impression of Change Scale is exactly that. It's one question which asks the patient, and I'll read it out for you, which statement most accurately describes your overall rating of improvement, so following a treatment, and satisfaction of your progress after the pain management program. So how they think they've done following a treatment. And there it is. Worse to very much improved. Okay, so that's 7 points, 2, 4, 6, 7 points. There are many other tests to measure pain. This is just a few, get you started. But these are the important ones, the ones that are useful. Now I'm going to briefly mention IMPACT, and there's the website, impact.org, the Initiative on Methods, Measurements and Pain Assessment in Clinical Trials. And it is a group. They've met a number of times now. They've been around since the early 2000s. And essentially what they aim to do is to develop a consensus with regards to reviews, recommendations, and improving designs, execution, and interpretation of clinical trials looking at pain treatment. So this is particularly focused on pain. So improving our pain management as far as trials go. And there are a number of them out there. The two main ones that I'm just going to focus on are the first two, so 2003, 2005. Most of these two are out of the journal Pain. Core outcome domains and core outcome domain measures. Okay, so what are the domains? What should we be measuring if we're doing trials in patients' pain, trials on pain? Now, outcome measures are very important and are very topical at the moment, and it is important because we need to be able to measure what we're doing. So these are the six. Six outcomes. Pain. These are the main domains. These are the main domains that we should be measuring: pain, physical function, emotional function, participant rating of improvements and satisfaction with treatment, symptoms, side effects, and the patient disposition, which I'll come to. So the outcome domains, I've mentioned there's 6 of them, but how do we measure them? So this is the outcome domains, the core domains, and the measurements of them. So pain, we should do self-reporting, which is the gold standard, and on top of that we could be adding in what rescue analgesics patients are taking and what are the other descriptors of pain, so the quality of pain descriptors. If we're measuring physical function, this is the second core domain. How do we measure physical function? We could use the BPI, so the brief pain inventory, which we've discussed, and the MPIIS, which is the multidimensional pain inventory interference scale. And I'm more familiar with the BPI, and there are other various measures that you could use when you're measuring patient function, and that depends on the trial. Emotional function, very important. The BDI, so the Beck Depression Inventory. Or the other one that they've recommended is the profile of mood states. I'll just go back. Participant rating, I've mentioned, so the global impression of change. So how have you gone following your intervention, treatment, trial strategy? And then there should be open-ended free text or prompts for symptoms and side effects in each trial. We should be putting this in. And then the participant disposition, which when you read that you're not really sure what that means, and that was what I thought when I initially read that. But what that means is we need information about the actual study subject, each subject, and this comes from the consort statement. Now the consort group ultimately is looking at improving the reporting of RCTs, so randomized trials. So the reporting of RCTs, this is not pain related, this is just random trials in general. And it's an evidence-based minimum set of reporting recommendations, participant disposition, and it gives the reader who's ever looking at the trial all the information they need to make an accurate appraisal of that trial. So it allows you to understand the trial design, it allows you to analyze, interpret the trial, and it gives more validity to the results as well. Consort. Complete transparency from authors, and many times have I sat down and looked at a paper and had many unanswered questions about how something was done or why something wasn't done, and if you follow the consort recommendations or the statement, this should be a thing of the past. Everything should be everything of value and that is necessary would be reported. Interestingly, consort, what does it stand for? Consolidated standards of reporting trials. So that's consort. There are many other, there are about 8 now or 10 papers by the impact group looking at various aspects. So there's the development of the measures, there's interpretation of the importance of the outcomes. There's one on ped impact, so looking at pediatric acute and chronic pain, and that's quite an interesting read, particularly for those of us involved with pediatric pain. How do we analyze endpoints, and a couple of others. So the impact group is doing a lot of work. So if you're involved in a paper on chronic pain, go to the impact recommendations and see if you can adjust your paper following these recommendations. The impact group is specific in that these recommendations are not needed for every trial. It's purely that, a recommendation. So that brings us to the end of our topic.